Melanie is a 72-year-old woman who has a 5-year history of progressive forgetfulness. She is no longer able to care for herself, and she's become increasingly depressed and paranoid. Recently, she started a fire in her kitchen. After excessive neurologic evaluation, Melanie was diagnosed with having Alzheimer's disease. Her husband and children have come to the Alzheimer's unit in your extended care facility for information about this disease and to discuss the possibility of placement for Melanie. You reassure the family that you have experience dealing with the questions and concerns that most people have in their situation. The question is, how would you explain Alzheimer's disease to the family? Well, Alzheimer's disease is a progressive degenerative disorder of the brain. It causes irreversible loss of memory and loss of mental functions. The brain atrophies or shrinks, and brain cells and nerve endings, which are the cerebral cortex neurons, they're destroyed. And currently there's no cure. At the rate of progression of Alzheimer's, the rate of progression of Alzheimer's varies from person to person. The time of onset until death usually ranges between 3 and 10 years, and the average is about 8 years. So, like I said, it's chronic, progressive, degenerative, accounting for 60% of the dementias occurring in people that are over 65 years of age, and eventually causes complete disorientation and total dependence on others for care. It is characterized by loss of memory, loss of judgment, visual spatial perception changes, and by a change in personality. So Melanie's husband, then says to you, how did she get it? We don't know anyone else who has it. How are you going to respond to that? Well, the most important risk factors are age, female gender, and family history. Clients who have experienced a head injury are at higher risk for Alzheimer's disease, and that also may cause it to manifest itself at an earlier age. We don't know the causes of Alzheimer's. Scientists have linked the disease to many possibilities, such as viruses, autoimmune disease, genetics, and deficiencies of neurotransmitters such as acetylcholine, somatostatin, and substance P, and norepinephrine, but no one knows for sure. So people usually show symptoms between the ages of 40 and 60, sometimes 3 to 15 years. I know previously said 3 to 10 years. And they become physically and mentally disabled or incapacitated. People with Alzheimer's disease often die of infection and or aspiration of pneumonia. After asking the family to describe Melanie's behavior, you determine that she is in stage 2 of Alzheimer's 3 stages. Common signs and symptoms for each stage of the disease. Please describe them. Well, on page 873 of your textbook is a great example of the 3 main stages of Alzheimer's disease. It also talks at chart number 4213. So we talked about Melanie being in the middle stage, which is stage 2. It's characterized by complete disorientation to time, place, and events, and the client can develop speech and language difficulties as well as incontinence. So what we see in that stage are impairment of all cognitive functions, problems with handling or unable to handle money and finances, disorientation to time, place, and event, possible depression, agitation, increasing dependence in activities of daily living, difficulty driving, gets lost, speech language deficits, less talkative, increased or a decreased use of vocabulary, increasing non-fluent, and eventually they become aphasic. They can be incontinent, and they may have trouble sleeping and begin wandering. The daughter expresses frustration at the number of tests Melanie had to undergo and the length of time it took for someone to diagnose Melanie's problem. What tests are likely to be performed, and how is Alzheimer's disease diagnosed? Well, initially they're going to do some blood tests to rule out any other possible causes of the symptoms. The usual tests are a CBC to rule out infection or severe anemia, a urinalysis to rule out infection, thyroid stimulating hormone to rule out hypothyroidism, and these are followed by tests for vitamin B12 deficiency, folate, to see if that's deficient, and they're also going to look for tertiary syphilis and other neurologic causes. Diagnosis is made by neurologic and mental status examination, and a CAT scan shows atrophy or actual shrinking of the brain. The MRI can show anatomic and biochemical changes. PET scans can measure regional blood flow, oxygen uptake, and the uptake of metabolism of glucose. An EEG will show abnormal or abnormally slow waves, and these tests rule out other disorders such as brain tumors, hydrocephalus, metabolic problems, and drug toxicity. A series of psychologic diagnostic tests are administered by a clinical psychologist. Some of the common tests we would see about or hear about are the geriatric depression scale, the mini mental state examination, 7-minute screen, clinical dementia rating, global disorientation scale, brief cognitive rating scale, and the functional assessment staging test. 90% of Alzheimer's cases are clinically diagnosed. Unfortunately, it can only be completely diagnosed after death through a microscopic examination of the brain looking for the tangles and plaques. One of the most important diagnostic goals is to rule out reversible types of dementia, or delirium or depression, alcohol or drug toxicity. So we want to rule that out before we actually make that dementia diagnosis. So a detailed past medical history and physical exam are very important in the diagnosis of Alzheimer's disease. It can rule out other types of dementia, but these tests must be completed, and that includes all the lab work, CBC, chemistry, thyroid, B12, all those things I talked about. So it can be very frustrating for the family. Melanie's husband states, "How are you going to care for her? She wanders around all night long. She can't find her way to the bathroom in a house she's lived in for 43 years. She can't be trusted to be alone anymore. She's almost burnt the house down. We're all exhausted, and there are 3 of us. We can't keep her up with her. You acknowledge how exhausted they are, and they must be from keeping her safe." So it's important to talk about to these family members the safety measures that are put into place. Oftentimes we can put deadbolts at the top of doors that they can't get out to put themselves in harm's way. We have different types of alarms and safety mechanisms that are put into place to keep individuals safe if they wander. Describe the Alzheimer's related nursing interventions related to the following nursing care problems. Well, self-care deficits. We would be continuously assessing her self-care needs and the ability that she has to participate in her care. We would provide direct care as needed. Sleep pattern disturbance. We would control her activities so she's awake during the day and provide measures to facilitate sleep at night. We would maintain an environment conducive to sleep and, if necessary, give appropriate medications. Impaired verbal communication. We would develop alternative patterns of communication for Melanie. We'd watch for subtle communication clues. We would anticipate her needs and make certain we would have her attention when we're speaking to her. Impaired cognitive function, we don't ask her to perform cognitive skills above her level of ability. We're going to control environmental stressors and reduce environmental stimuli and develop and maintain a daily routine and a continuity of care. We would use validation theory, which involves acknowledgement of the client's feelings and concerns. It is more effective in the later stages of the disease, when using reality orientation only increases their agitation. So we would use validation theory for them. I'm going to make you look that up in Iggy. Risk for injury, kind of talked about that earlier. Constant supervision, deadbolt locks like I talked about, gated communities. We would maintain a safe environment, provide any anti-seizures, antipsychotics, antidepressants, or sedative if ordered. Self-care deficits, we kind of talked about that, but self-care deficit related to swallowing and underweight status, so we'd thicken fluids up so that we would prevent any aspiration risks. And the agitation is often caused by a changing daily routine. We've talked about sundowning, a condition called sundowning, where the agitated behavior is in late afternoon or the evening. It may increase in either if the environment or the patient's activities patterns are changed. So it's important to develop a consistent day-to-day activity to control that agitation. So Melanie's son asks you what the different medications might be prescribed for Melanie, and how are you going to describe that to them? The anti-seizure medication, as the disease progresses and more brain cells and nerve endings are destroyed, there is a chance that she's going to develop seizures. And these medications will be prescribed only if there is a seizure. Cognitive function medications, cholinesterase inhibitors like Aricept or Exelon or Rimonel, they could be ordered to improve cognitive function. It's important to tell the family that these may slow the disease, but they're not going to cure it or not going to stop it or halt it in any way. It will slow it. Antipsychotic medications, she has exhibited paranoid behavior, and that medication would minimize her distress and minimize her antisocial behavior. They're generally not prescribed unless the patient is having hallucinations. Also, the newer medications generally have fewer side effects than the older antipsychotics. Anticonvulsants. Sometimes physicians will use an anticonvulsant stabilizer for hostility or aggression. Antidepressants, it should help relieve her depression, low mood, irritability. About 25% of Alzheimer's patients have some depressive symptoms. Sedatives should allow her to sleep at night and decrease her continuous daytime wandering. Sedatives are used in combination with behavior modification. So once again, activities during the day to make sure there's a good sleep at night. Anti-anxiety, we know that Alzheimer's patients often demonstrate anxiety, restless, and verbally disruptive behavior, so the anti-anxiety helps it. Other medications that have failed to show great promise are the NSAIDs or the statins, HMG-CoA reductase inhibitors, vitamin E, and ginkgo biloba extract have not shown helpful at all. But the medications themselves are not to improve the dementia, but they're to help control the emotional responses. You try to comfort the family by telling them about that the problems they experience are very common, and you explain to the family support that family support is a major focus of your program, and list 4 ways how Melanie's family might receive the support that they need. So you would use active listening, encouraging support groups, respite care, monitor for caregiver role strain, which they obviously already have just by listening and talking to them, especially the husband, and to maintain their own social contacts and leisure activities. So you would provide opening, up-to-date information about Alzheimer's disease, specifics that are related to Melanie. You would, encourage them to attend support groups, see if there's legal or they need any legal, financial advice, community resources that are reputable. Huntington's disease is often abbreviated as HD. It was first described back in 1872 by, guess who? Dr. George Huntington. So it affects men and women alike. It occurs at a rate of 1 in every 10,000 in most Western countries. People with Huntington's need dedicated care and support from their loved ones, which makes a number of lives are touched by the disease is even greater than the individual who has it. The age of onset of this disease is between 30 and 50 years of age, although there is a form of Huntington's disease that affects children and teenagers. People with Huntington's can express a wide variety of symptoms, which physicians typically group into 3 categories. There's movement, cognitive, and psychiatric symptoms. Basic control is altered. Some of the movement symptoms include spasm, tics, rigidity. They have jerky hand movements. There's falling down, difficulty physically producing speech, and in the later stages of the disease, difficulty swallowing, so that can lead to weight loss, aspiration risks. The uncontrolled movements such as writhing and twisting are often common diseases or symptoms of Huntington's, and it's often referred to as a chorea. So at one time this disease was called Huntington's chorea. The most significant cognitive symptoms of Huntington's disease are the altered organization and generally slowing of the processing of the information in the brain. These symptoms can lead to difficulty learning new things, planning and prioritizing, impairment of one's perception of space, like tables and walls, that kind of thing. Difficulty multitasking. They have a hard time paying attention to several things at once. Individuals frequently adhere to common routines because their routines are easiest for them to accomplish. Sorry, my dog's in the background here, but I'm just going to continue. Finally, because they have trouble organizing incoming and outgoing words in their brains, many people experience difficulty communicating. Depression is the most common psychiatric symptom, and other symptoms include personality changes, apathy, anxiety, irritability, obsession with certain activities like hand washing, delirium, mania. Denial of having Huntington's disease is also a common symptom of the disease. Somewhere between 10 and 25 years after the symptoms appear, it usually takes a toll on individuals and they die of pneumonia, heart failure, or other complications. It is a single gene disorder caused by a mutation in the Huntington gene IT15 located on chromosome number 4. The mutation is a multiple repeat of specific base triplet CAG, increasing the length of the gene. An autosomal dominant trait with high penetrance means that the person who inherits just one mutated allele is nearly 100% chance of developing the disease. This gene mutation has several different expressions depending on whether it's inherited from the mother or the father. People who inherit the mutation from their fathers have an earlier onset and a shorter life expectancy than those who inherit from their mothers. In addition, there's some variation in the disease depending on the size, which would be the length of the mutation. The longer the mutation, the more severe the disease is at an earlier age. The following slide is a nice example of comparison between Huntington's disease and Alzheimer's disease and their abilities. So I don't have anything further to say on that.